This is
Membership
for,
of 100.
no, this is the first one we are having for Navi Mumbai.
Vijayawada Obigani Society, we have a membership of around 320 members.
Okay.
So we did one for us, and we have to do 2 more sessions because it allows 100 people to come into the session at a time.
Okay.
The other speakers, sir?
I think few of them have joined. Yeah, Krutika is there. Archana is there with me here itself. So 4 speakers are there. So
Yeah, speakers are in time.
Good afternoon, madam. Good afternoon, sir. Madam, I am Krutika Arunachalam. I'm the 4th speaker. I'll be taking the counseling part.
Excellent, excellent.
our secretary is also here. Dr. Santosh is also here.
Okay, that's great.
Wait till 3:30.
Yes, yes.
2 minutes more. So we are waiting for Ankita to join in.
Okay. Shriman, you're here. He's the person who's at meaty events. The other day, there was some problem with me sharing when that video had to play. So I didn't want that hitch to happen. So I was just trying out. Dr. Rahul Vani, with your permission, can I just try sharing this?
Yeah, please do.
The audio works.
Yeah, please go ahead.
Is there an audio of this, or could you just see the pictures?
Play it again, ma'am.
Audio is there, but it's very faint. So you'll have to increase the volume, ma'am.
Madam, there is only video playing, madam. There is no audio. I'll tell you, madam. Please stop sharing the screen. I'll tell you.
Yes, this one was one thing I was having a problem, Shriman. Okay, what do you want me to do?
I'll tell you, madam. See, when you start sharing the screen,
okay,
in the left side
down,
you'll have share sound
is there.
And optimize. There are 2 check-ins. You have to check in before sharing the video.
You want me to check both? Click
yes,
both.
madam. You have to check in both. Then you have to share this video.
And respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva.
Now the voice was quite good.
Okay. So that was okay now?
Yes, madam.
Yes, fine.
I'll be there, madam. If you need any technical help, please, you can call me.
Yeah, definitely. Oh, that's great.
Santosh, can we start? Ankita is around.
I'm just calling Ankita in a minute.
Yeah. No, she has to join on the same link. There's no separate faculty.
Yeah, she's trying to join. She'll come in a minute, I suppose.
Right, Sriman? There's no separate link. No? Everybody has to join on this link.
Yes, sir, there is a separate link, sir.
Yes,
I've already registered for madam. The link has been sent to her mail ID also. Madam has to check her mail ID.
Yeah. Till Ankita joins, I think we should start with a little introduction about the whole program. This FOXY WHO Respectful Abortion Care Program is basically making the MTP services more available and widely available. Because of this amendment in 2021, which has come in, it has made the MTP law a little more liberal than it was before, and so that the abortion services can be taken off. What is found is the maternal mortality rates and the morbidity rates. Almost 8% of maternal mortality is thought to be because of unsafe abortions. So that is why the whole of this respectful abortion care program is about providing MTP services to the woman who wants it, and more liberally within the four frameworks of the law, So it is about this. So we will slowly start. We'll begin our programs shortly. We're just waiting for Ankita to join.
Yeah, join.
Good afternoon, sir.
Good
Sir,
afternoon.
am I audible?
Yes, you are audible.
Yes.
You are not visible.
Yeah.
You are.
Sir, am I audible?
Yes.
Yes.
So is the video visible?
Yeah.
Yes, sir. Okay. So should we have 20 participants now, sir. Should we begin or should we take some time?
We'll start.
Okay. Thanks. A very warm welcome to all the delegates today. I take pleasure in inviting everybody this evening for Navi Mumbai's Obstetrics and Gynec Society's webinar on safe abortion practices. With the new rules now coming, it is important that we refresh what we already know and we learn what new has been put forward. Let's begin today evening session without any further delay. To deliver our first lecture on respectable abortion care, I would like to invite our president for Navi Mumbai Obstetrics and Gynec Society, Dr. Rahul Vani sir, to deliver the lecture. Dr. Rahul Vani sir is the president for Navi Mumbai Obstetrics and Gynecological Society. He is the senior obstetrician and gynecologist practicing in Navi Mumbai area. Honorary consultant at Mathurdi Hospital Trust, associate medical legal consultant, BNS Medical Legal Consultancies, and he's the member of Ethics and Medical Legal Committee FOXY, also a member state oversight committee for HIV/AIDS and lead assessor Manyata project for FOXY. Over to you, sir.
Thank you, Ankita, for the introduction. So I'll start sharing my screen.
Yes, sir.
Yeah. Okay. So I will be talking about the latest amendments under the MTP Act. and how has it made it more liberal so that more and more women can access safe abortion services. So what is the amendment that we'll look at? What are the changes in rules? So now, why was this amendment sought after, and it took a lot of years for this amendment to come? But the main purpose behind this was to make the abortion services more reachable to every woman who wants it, and it should be safe. Now, it is considered that 8% of maternal deaths per year are due to abortions, and it is the third most leading cause of maternal mortality and morbidity. It is considered that nearly 2 out of 3 of the abortions performed are unsafe abortions, and nearly half of the pregnancy-related deaths are in women and girls under 24 years of age. So this is a huge national wastage of young women and girls dying at less than 24 years of age. So how can we make this safer so that they do not have to go for unsafe abortions? That is the whole idea behind this amendments. Now, when is abortion considered safe? So as per the World Health Organization, safe abortion has 2 components. One is it is done with appropriate methods, and it is done by trained persons. So when both these criteria are met, it is considered to be safe abortion. Now, if only one of the criteria is met, like if it is done with appropriate methods but not by trained people, then it is less safe. Or it is done by trained persons but not by appropriate methods, then also it is less safe. And unsafe abortion is when both the criteria are not met. It is appropriate methods are not used and trained persons are not doing it, then it is considered as unsafe abortion. So what are the amendments which have come in this 2021 Act? Let us have a closer look at this. Now, this is the amendment about provider. Now, previously we required opinion of one provider for MTP up to 12 weeks, and there was a requirement of 2 providers for MTP for between 12 to 20 weeks, and MTP was limited up to 20 weeks. So this provider opinion form we used to fill in Form 1. Form 1, it had options to give 2 doctors. Up to 12 weeks, we need to give only 1 doctor. Up to 20 weeks, we had to give 2 doctors' opinion on that form. Now, the 2021 amendment has changed all this. Now, we require opinion of only 1 registered medical practitioner for termination of pregnancy up to 20 weeks of gestation. And accordingly, the Form 1 has also changed. The Form 1, the new Form 1 is available on the net, and anybody can download it. It has option for giving only 1 registered medical practitioner's name in it. So then the options of 2 medical representatives is not there, or 2 opinions of 2 doctors is not there on Form 1 now. And requirement of opinion of 2 registered medical practitioners for termination of pregnancy is required only after 20 weeks. So between 20 to 24 weeks, with opinion of 2 registered medical practitioners, you can go ahead and do the termination. Now, the indications for termination in both less than 20 weeks and 20 to 24 weeks is a little different. That we will see a little later. Now, what is the potential outcome of changing this provider criteria? What happens because of this is there is increase in the number of facilities, especially in the government and the PHC centers, which become eligible for providing services up to 20 weeks. So now most of these PHCs were manned only with one medical officer, and since there was no availability of the second doctor, they could not conduct terminations between 12 to 20 weeks, and they had to send it to higher centers. And this is where these patients were not willing to travel to higher centers or civil hospitals or higher government hospitals, and they used to seek unsafe abortions. So this is how it will increase the accessibility of abortion services at least up to 20 weeks to the most rural areas. So modification for vulnerable group of women. Now this has been brought about for that 20 to 24 weeks of gestation. Previous Act, MTP was permissible beyond 20 weeks only and only when it was absolutely necessary to save the life of the mother. Now with this amendment, we have two criteria, 20 to 24 weeks and beyond 24 weeks also. Now, between 20 to 24 weeks, the criteria for giving termination is rape survivors or minors, and if there is a disability, permanent disability. So the criteria have changed a little, and in the Form E, all those criteria have been prescribed or they have been written there. So anybody can go through it, and if it falls into those indications, you can go ahead and do the termination between 20 to 24 weeks. It is not only for congenital malformations. There are other criteria like I said, rape survivors or minors, or if there is a permanent disability. There is also a criteria if there is a change in marital status of the woman during her pregnancy. Suppose if she becomes a widow during her pregnancy and the pregnancy is less than 24 weeks, she can seek termination of pregnancy, or her husband leaves her and there is a divorce between the two. So in case of this changed marital status also, she can undergo a termination between 20 to 24 weeks of pregnancy. And beyond 24 weeks, birth defects which are not compatible with life, here you have to take the opinion of the medical board which will be constituted, and this medical board has to give its opinion within 48 to 72 hours in Form D, and you can go ahead and do the termination if the birth defect is not compatible with life. So as soon as these medical boards are formed, it will be gazetted, and it will be more and more information and awareness will be created about this medical board. So we don't have to go to the courts. You can apply to these medical boards and you can seek terminations. Now, potential outcome of this change is increased access to vulnerable women to safe and legal abortion services, defined by rules including violence victims, minors, among others. The previous act, now modification of birth defects and congenital anomalies. As I told you, the upper limit for birth defects which is not compatible with life, there is no upper limit. They can go ahead and do the termination. Only thing is beyond 24 weeks, registered medical practitioners cannot decide upon the termination. They have to apply to the medical board, and the medical board will give its opinion in Form D. And once they have given their opinion, if they have approved the termination, you can go ahead and terminate this pregnancy. So previously, because of these restrictions, if there was no indication for termination of pregnancies beyond, say, 12 weeks or beyond 20 weeks, and you used to have beyond 20 weeks, you had to approach the court, and that was more cumbersome. So people would rather seek unsafe abortions rather than going for safe abortion. So this has widened the scope, and they can legally access the abortion services. So that is what this liberalization of this MTP Act has done. I talked about modification relating to marital status between 20 to 24 weeks. There is similar change for less than 20 weeks also. Initially, failure of contraception was an indication only for married couple. Now this has been extended to any couple. So they need not be married, and this is up to 20 weeks. So failure of contraception as an indication can be used only up to 20 weeks. Between 20 to 24 weeks, there is no indication of failure of contraception. This is to be remembered very, very properly, so that we don't use that failure of contraception indication for termination of pregnancies between 20 to 24 weeks. Now, there is a new clause of privacy. The medical termination of pregnancy previous act said that the information should not be disclosed. But here, it has specifically also said that name and other particulars of a woman whose pregnancy has been terminated should not be revealed to any other person unless it is authorized by law. And it has also made it stricter. The previous law, this confidentiality part used to come under regulations. And to break this, if you violated this regulation, the fine was only 1,000 rupees. Now, under the amended act, if you reveal the confidentiality or you expose the confidentiality of the patient, the penalty is as much as 1 lakh rupees. So you need to be more careful about maintaining the confidentiality of the patient. These are the salient features. It prioritizes confidentiality and safety. Confidentiality has to be maintained at all points of time. How to maintain the confidentiality was already there in the previous act or the act before this amendment. The ground of failure of contraception has been increased to any woman and her partner. It need not be just a married couple. Now it also defines the special or vulnerable category of women eligible for extended gestation period termination between 20 to 24 weeks. As I said, it has been enumerated under the Form E, who can undergo termination and who are the special and vulnerable category of women. Norms for registered medical practitioner have also been defined. Now there is also a new criteria, less than 9 weeks, where medical pills can be given, and 9 to 12 weeks. So they have clearly specified who can give tablets up to 9 weeks, who can do terminations up to 12 weeks, who can do terminations up to 20 weeks, who can do termination up to 24 weeks. So all this has been clearly mentioned in the amendment rules. And they have also enumerated the powers and functions of the medical boards which will be constituted for providing terminations beyond 24 weeks of gestation. So these medical boards will consist of one OBGYN specialist, one pediatrician, and one radiologist. And the time limit has been set to this into these medical boards. Once you apply to the medical boards, they have to give their opinion within 72 hours. It is not that once you apply, you have to wait for a long time. So the time has been given within the rules itself. They have to reply within a specific time. Now, what are these special category of women which are eligible for MTP between 20 to 24 weeks? So as I said, the survivor of sexual assaults like rape, incest, women with pregnancy in humanitarian settings, disaster, emergency situations as declared by government. Now, the recent COVID pandemic could be one of the emergency situation where terminations could be allowed between 20 to 24 weeks. So such emergencies which would be there, or such disasters which will be there, the government can notify these are emergency situations, and during that time, women may be able to undergo terminations between 20 to 24 weeks. Now, change of marital status during the ongoing pregnancy, like widowhood and divorce. Women with physical disabilities, major disabilities as per criteria under the Disability Act. Mentally ill women, including mental retardations, they also can seek abortions between 20 to 24 weeks. All minors can seek terminations between 20 to 24 weeks. And fetal malformation, that has substantial risk of being incompatible with life, or if the child would suffer from such physical or mental abnormalities to be seriously handicapped. So all these are indications which are given under that Form E, where you can terminate the pregnancies between 20 to 24 weeks. Now remember, this Form E is different. This is a new form, and when you are terminating pregnancies between 20 to 24 weeks, you have to fill up this Form E, not the Form 1. And you require opinion of 2 doctors on this Form E. Now, as I said, the norms for registered medical practitioners who can do terminations up to what gestational period has also been given in this Amendment Act. Registered medical practitioners defined in the old Act was as MBBS or more with any. If an MBBS doctor has assisted 25 cases of MTP, of which at least 5 have been done independently, or medical practitioner who has completed 6 months of house surgency in obstetrics and gynecology in any hospital, and medical practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. So all of us who have postgraduate degrees or diplomas, we are called as registered under the definition of registered medical practitioners. We get covered, and we can do MTPs. Medical practitioner who has experience of at least 1 year in practice of obstetrics and gynecology in any hospitals. So this was the definition of registered medical practitioner in the old Act. Now, under the amended rules 2021, an additional category of provider has been added. Now, for termination up to 9 weeks with medical methods, registered medical practitioner is experienced in the practice of obstetrics and gynecology at any hospital for 3 months. So for prescribing tablets, he does not need to have a 6 months experience, or he need not have assisted 25 MTPs and done 5 independently. If he has 3 months experience in any of the hospitals, he can prescribe the tablets from his clinic, provided that he has a link with some hospital where he can refer the patient in an emergency. Along with this 3 months experience, training with performance of 10 cases of MTP by medical abortion under medical method of abortion under supervision of registered medical practitioner in hospital, maintained, or a training institute approved for this purpose by the government. So if he has done some 3 months in a hospital which is recognized for MTP, he has performed 10 MTP by medical methods under the supervision of a registered medical practitioner. He can prescribe these medications or medical abortion pills from his clinic. So the norms for the registered medical practitioner whose opinion is required for termination at different gestational ages: till 9 weeks, as we just said, experience at any hospital for 3 months in the practice of obstetric and gynecology, or has independently performed 10 cases of MTP by medical methods under supervision of a registered medical practitioner in a hospital established or maintained, means any of our hospitals which are recognized for MTP, or a training institute approved for this purpose by the government. Second, MBBS doctor, a practitioner who has assisted a registered medical practitioner in performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. So what you see is this category 1 has been added in this amended act. So all these categories, all these 2, 3, 4, 5 was there initially. Now this new category has been added specifically for medical methods of abortion. So up to 9 weeks, all of them can give medical pills, right? All the 5 category of doctor, or 5 or 6 categories. Beyond 9 weeks, that category of 3 months experience and 10 medical abortion, that goes off. Rest of the 4 categories who have assisted 25 MTPs, done 5 independently, or 6 months experience in obstetrics and gynecology, house residency post-EP has done, or 1 year practice in obstetrics and gynecology in any hospital, and any postgraduate degree or diploma holder can do MTPs up to 12 weeks of gestation. Now, beyond 12 weeks of gestation, the second criteria goes off. The registered medical practitioner who has assisted 25 and done independently 5, they cannot do beyond 12 weeks. The postgraduate degree holder, 6 months experience, house residency in obstetric gynecology, and 1 year experience in obstetric and gynecology. So these 3 criteria can do terminations up to 20 weeks. Now beyond 20 weeks, or beyond between 20 to 24 weeks, all these 3 criteria, these 3 category of registered medical practitioners can do the termination. And beyond 24 weeks, again, it is a postgraduate degree or diploma holder and experience of 1 year, not less than 1 year. So it has further reduced, and this has to be only after the opinion of the medical board. So you see how with different gestational age, the registered medical practitioners who can provide the services changes. As I said, the composition of the medical boards would be a gynecologist, pediatrician, and a radiologist or sonologist. What are their powers? Once an application is received, they have to allow or deny the termination of pregnancy beyond 24 weeks of gestation period, after considering all the facts, circumstances, and what are the morbidities, or what is the malformation in the child. With that, they will form an opinion, and they have to give their opinion in a limited time. If they have any difficulty in forming an opinion, they can co-opt other specialities in the board and ask for additional investigations. They can to examine. They will examine the woman, her reports, and provide the opinion of the medical board in Form D with regard to the termination of pregnancy within 3 days. So within 72 hours of receiving the request, they have to give their opinion. and they have to ensure that the termination procedure, when advised by the, is carried out with all safety precautions along with appropriate counseling within 5 days of the receipt of the request. So they have to give their opinion in 3 days, and that once they have given their opinion in next 2 days, the termination has to be done. So within 5 days, the whole process has to be completed from application till the process of termination, or for the initiation of process of termination. So thank you. That was about the amended act. If you have any queries on this amended acts, if you want to ask any questions, you can ask right now.
Thank you so much, sir. Thank you for such a crisp and a detailed lecture on the recent amendment. Any questions in the chat can be asked in the chat section, please. Who should apply to medical board, patient or the doctor?
Medical board, your doctor can give an application to the medical board along with the patients.
Thank you so much, sir. Any other questions can be please shared in the chat section, and then we will go back to the questions after the lecture. Proceeding on to the next lecture for the evening.
Ankita, can I just step in just for half a
Yes,
minute?
sir, please.
Yeah.
Yes,
Good
sir.
afternoon, everyone.
Yes,
Rahul, so nice to see you after exchanging tons of mails back and forth. And Santosh, to you too. I know you've been working in the background to make sure everything went smoothly. And indeed, it is. I'm delighted to see it did come out to be smooth.
Yeah.
Pooja, wonderful to see you once again. Padmaja has been a star both in the Dhira program and now here as well.
Thank you, Ajay.
Colleague, thank you so much for being here. It's an absolute honor. I come from Mumbai, but I'm settled, in different parts of the world actually. But right now I'm in Delhi. I've just moved in from Dhaka. But it's always a pleasure being, associated with programs and work which is related to what we are doing. I'm sure in the inaugural or the opening chat, we must have shared this is a FOXY and a WHO program where WHO, along with Government of India, Ministry of Health and Family Welfare are key people responsible for making sure the new act actually finds its way to where it is. And it has almost taken us 50 years now to call it the respectful abortion care. And that is the definition that we have now. And that is what each and every faculty from Rahul to Archana to Padmaja will be talking about today. And thank you very much for presenting, Rahul, that crisp presentation and absolutely on the money in terms of what we had to communicate. Do put in your queries in the chat box and we'll try to reply them. I'll be jumping between two sessions. The two of them are happening parallelly. Santosh, you know about that.
Yeah, I know.
So bear with me. Two operational things which I just wanted to share with you before I get on to that in case I miss that, Firstly, in order to get your certification, 5 things are very compulsory. First is the attendance itself, and that's the reason why you're here. The second bit is related to registration and pre-test, which also each one of us have completed, and that's the reason why you're here. At the end of the session, at the end of the 4th topic, which is pre-post and pre-counseling session, after which we will put it in the chat box, a link. This link, once you click on it, will take you to the post-test and feedback. You submit that through that link. In case some of you miss that link in the chat box, when you leave the meeting, that means when you click on leave and leave the meeting, a pop-up will again come requesting you to submit the survey, which is essentially post-test and feedback. So you will still get a second opportunity. Third opportunity will still be there. It's like, the benefit of the doubt is always with the batsman. Padmaja knows this very well because I've done about 120 sessions so far. And this is repeated, tirelessly and patiently with everyone. So the third opportunity for you, only for people who have not submitted in the first 2 opportunities, an individual email will go to you, again sharing the links. So we will, make sure that you have every opportunity to do that. And thereafter, if it still doesn't happen, you can write one-on-one. We will still give you an opportunity because each one of us is working together. And this is not to hold back on anything. It's something which you deserve and you have worked for it. And therefore, you need to get it. I'm extremely delighted. That's the second part. Delighted to share NMOGS having conducted this program amongst the first one in Maharashtra. So huge congratulations to OGS. And as a token of our gesture, we have negotiated with the funder that each society who completes the program and tries to reach the, so you have an opportunity to do a second and third program also till you actually complete your members. A very token honorarium is going to be shared with the society. So NMGOS, please be cognizant of that. A small token will be coming to you. Not that you expected it, not that that is a motivation for each one of you. You're self-motivated, and that's the reason why you're doing this program. But Shanta and myself, we felt that this is something the societies deserve for the work that they're putting in and all the effort that they're going to put in. So that you can await that. If your account details are already with Foxy, then it should happen very fast. If not, my office will be writing to all of the societies who have conducted the program. Please do share your bank account details there, and let her know. Her name is Manisha, so she will use my reference and send a mail to all of you all. Please share those details so that that amount can be transferred. So on that happy note, please continue, Ankita, and I will hop in the other one, and I'll keep coming back here in case there are some operational questions or any programmatic related questions that we could perhaps answer. All the very best.
Thank you, sir.
So there are some questions I read in the chat box.
Yes, sir. So can we go ahead with questions? There are a few more questions.
Yeah, 2-3 questions we'll answer, and then we'll go to the next. Quickly, I'll answer them.
Yes,
you did not require consent of the spouse in MTP. It was not required earlier also. It is not required under this law also. So consent of spouse is not required. The other question asked was whether BMS doctor can prescribe. Now there is a definition of registered medical practitioner, which is MBBS doctor or allopathic doctor. So currently BMS doctors are not in that umbrella of registered medical practitioner under the MTP Act. If the government decides later on to integrate Ayush into this, they might do it, but right now they are not under the umbrella of this MTP Act. So BMS doctor cannot prescribe. That was the second answer. Third, how to apply to the medical boards. These medical boards will be published. They will be we all will be aware of these medical boards sooner or later. The government is going to publicize them, and once they are published, we will come to know where to apply and how to apply to them. So till then, just hold on. It will come very soon.
Yeah, and to add to what you have already mentioned, see, that's to me, it's a big gray area right now. So while these guidelines and rules and acts have been issued, by the time it actually trickles down to the state and dissemination happens, there will be a yawning gap. And in that yawning gap, some states may be coming and form those boards, and some may still be lagging behind. But the critical thing is, one of the important aspects of having those members and the qualification that is required from the government setup, you will realize that almost 80%, 87% of the vacancy seats are vacant for those positions in those institutions. So, you know, unless they are filled, so it's a catch-22, unless they are filled, how it all is going to happen and how it's going to be taken forward. Having said that, you still have an option of approaching a medical board in terms of an institution like a medical college. The Department of OBGYN can set up an independent, a committee or a group of people who, chaired by the head of the department, who can take such decisions because they are in that position of authority given to them through a government or a government medical college. So you have options. We try to work around that. And as Rahul has rightly pointed out, we will try to consolidate such lists whenever possible. And Foxy will work closely with the government and WHO and keep sharing this information with the members.
Now, to get these amendments, we had to put in a lot of pressure to the governments through the court cases. So beyond 24 weeks, that option is still open. We can approach the courts and probably pressurize the governments to form these boards as early as possible. Yep. So beyond 24 weeks, still cases are going to courts. So recently in last week also, I think Hyderabad, there was a judgment from Hyderabad where the High Court gave this judgment to form the medical board. So these boards will come sooner or later. Till then, we have the option to go to the court and pressurize the government.
Absolutely.
Okay, we'll move on to the next topic.
Yes, please. Thank you.
Yes, sir. So there are just two more questions.
Yeah.
Second last question is, do we need a new separate registration for MTP between 20 to 24 weeks?
Now, as per the Act and the rules, they have said in the rules itself, wherever it is 20 weeks, read it as 24 weeks. So all the hospitals which have been registered till 20 weeks are automatically registered till 24 weeks. So you do not require a separate registration for that. You need not apply again for registration. But the hospitals which are registered only up to 12 weeks, they cannot terminate beyond 12 weeks. So if they have to terminate for 20 weeks, need termination for 20 weeks, then probably they will have to apply, because there is no specific such mention in the amended Act or rules. So up to hospitals registered up to 20 weeks can do terminations up to 24 weeks. Up to 12 weeks will have to stay restricted to 12 weeks.
And the last question beyond.
Yeah. Tell me.
So should I go ahead?
Yeah.
So beyond 20 weeks, where should be termination done? Preferably private hospital or a government setup?
So beyond 20 to 24 weeks, the criteria is 2 registered medical practitioners can form an opinion that it is necessary to terminate this pregnancy, and they can terminate it in any hospital which is registered up to 24 weeks. That means up to 20 weeks. So there is no specific criteria with that it has to be done in a private or public. 2 registered medical practitioners forming opinion done in a registered center. That's it.
Thank you so much, sir. Now moving on to the next talk for the session today. I would like to invite to deliver the next talk on safe abortion, updates in technology, availability, quality of medicines and methods available by Dr. Archana Vani. Dr. Archana Vani ma'am is a senior obstetrician and gynecologist in Navi Mumbai, practicing at Archana Maternity Nursing Home since the last 20 years. Over to you, ma'am.
Thank you, Ankita, and good afternoon, everyone. Thank you, Foxy RAC committee, for initiating this wonderful program of respectful abortion care. We heard Dr. Rahul Vani speaking about MTP Acts and its amendments in the last talk. Within the law boundaries, how to provide these methods of abortion to our clients. That is what we are going to see in the second module of techniques of abortion, the updates on the techniques of abortion. We know that almost 6 out of 10 unintended pregnancies land up with abortions. Out of these, 43% are almost unsafe abortions, and 97% are in the developing countries. So whenever these abortions are unsafe, it increases the maternal morbidity and mortality in the reproductive age group. Increasing morbidity and mortality in this age group is not a positive factor on the healthcare system. So to control this morbidity and mortality, WHO has various guidelines have been set up by WHO on the safe abortion techniques. These global guidelines by WHO has been accepted as our the national guidelines by the Ministry of Health and Family Welfare. These guidelines mainly, all these guidelines have 3 key areas in the management of safe abortion. The guidelines, they focus mainly on the pre-abortion care, then providing the methods of abortion care. After that comes the aftercare and follow-up of these abortion patients, which includes the post-abortion follow-up as well as contraception counseling. In the pre-abortion care, taking, as we can see in this slide, the decision making by the patient and by the provider is very important. That we try and find out whether the client is eligible for the method of abortion or not. So in trying to find out about this, we need to take the detailed history of the pre-abortion assessment and counseling is mainly taking about the detailed history of the patient, general physical and pelvic examination, then laboratory and other investigations, and reaching to the diagnosis, whether this patient is fit to undergo the abortion and which method can be provided for this patient. Once the decision is made, the patient has to be counseled regarding these methods of abortion. We need to tell them about the pros and cons of those methods which are suitable for that. In the detailed history taking, very important to note down the demographic details of the patient, like which will help us to fill up the our records also. Then next coming the menstrual history, we have to find out whether the LMP is correct or not, whether her cycles are short or whether the cycles are regular or not. After the menstrual history, we need to note down about the obstetric history of the patient, with how many how many living children she has, whether there is any past history of abortions, and whether there were any complications noted in those abortions. In the current pregnancy, whether she has taken any abortifacient or not, or whether this is the continuation of that previous abortion, whether there is lactational amenorrhea which is going on. After the detailed history taking of the patient, then we should need to note down about the medical and the surgical history as well. There are certain factors which may turn out to be hazardous if the medical conditions are there, like if the patient has uncontrolled hypertension, or if the patient has a previous history of any AKT taken, or if the patient is a known patient of a chronic adrenal failure, if there are any cardiac diseases or other medical histories in the patient, that needs to be noted down, because giving an abortifacient to such patients may make the prevalent existing condition of the patient more risky. If the patient has a previous history of ectopic pregnancy, that also needs to be found out, and we need to find out that also. In the surgical history, if there is a history of scarred uterus or not, that needs to be noted down. When the history is taken, going ahead with the examination of the patient, in the general examination, need to note down about the pallor. Rule out anemia is very important, because if the patient is already anemic and we give them medical abortion, if she bleeds heavily, will deteriorate her condition. In the general examination, if any positive medical history is there, we need to note down regarding that medical history. We need to find out whether any signs are positive in the patient or not. In the systemic examination, abdominal examination, see whether we can feel the uterus or not, and in the pelvic examination, need to correlate the gestational size, need to correlate the uterine size with the LMP gestational age. So after 4 weeks, it is said that the uterine size increases by almost 1 centimeter per week. By 12 weeks, we can feel the uterus per abdomen. By 16 weeks, it is between the symphysis pubis and the umbilicus, and at 20 weeks, it is we can assist on the per abdominal examination. But there are certain limitations to dating the uterine size by physical examination. Like if the uterus has some malformations, or if there's a fibroid uterus, or in cases of multiple gestation, molar pregnancies, in those cases, the size may be bigger and the pregnancy may be smaller. Or if there is a markedly uterine retrovision, then you may not be able to feel the size properly. Or obese patient, we may not be able to assess the uterine size adequately. On examination, if you feel that the uterus is smaller than expected, it may indicate that the patient may not be pregnant, or it may be her menstrual dating is wrong, or it may be a missed abortion or spontaneous, already she has aborted, or it may be an ectopic pregnancy also. If the size is bigger than the expected gestational age by LMP, it might be either a fibroid uterus, multiple pregnancy, molar pregnancy. Just by doing a per-vaginal examination, if you are not convinced about the gestational age, you cannot correlate with her LMP, then we need to do a sonography and confirm her gestational age. But routinely, sonography is not required investigation for the for providing the method of abortion to the patient, as well as the other routine lab tests are also not a prerequisite for providing the abortion services. If we feel that the patient is pale, then we may go for a hemoglobin or a CBC estimation. And if the RH or the blood group is not known, in those cases, we can go ahead, we need to know the blood group and RH testing of the patient. On clinical examination, if we find any signs of infection, then we should rule out the STIs. And if on the medical examination we had some doubt about some of the medical conditions, then we need to do relevant investigations according to the medical history. After the pre-abortion counseling, when we are convinced about the gestational age, and according to us that the patient is, depending upon the gestational age, we feel that this patient is suitable for that method of abortion, then a pre-abortion counseling regarding the general counseling and the method appropriate counseling should be done. In the general counseling, we need to know why she wants to abort the particular pregnancy, whether this is her own decision or it has been forced on her. That is very important to know. Also, we need to inform her that earlier the abortion is done, it is safer. It has to be done by a provider who is trained in that particular surgery or by trained for that particular procedure. Whatever method of abortions which are available according to her gestational age should be explained to her, and the methods, whatever risks and warning signs are associated with that should be told to her. We need to counsel her that once the abortion is done, within 14 days, the patient reverts back to her fertility potential and she can still become pregnant within as early as 14 days after the abortion. She can resume back her regular activities and after the abortion, including the sexual intercourse also. And we need to document her written consent in the consent form. The decision regarding the contraceptive acceptance is also should be noted, but if the patient is not willing to accept the contraception, is not the criteria to not provide her abortion methods. So once we are sure that she is so many weeks of gestational age, we have the different methods for less than 12 weeks and more than 12 weeks abortions. In less than 12 weeks abortion, we have medical methods and surgical methods. In less than 12 weeks, the medical methods is combination of mifepristone and mesoprestol or only mesoprestol, and the medical method, the surgical methods are vacuum aspiration method. For more than 12 weeks also, we have medical methods similar to less than 12 weeks, but the surgical method is dilatation and evacuation. Sharp curettage is normally not recommended. In the less than 9 weeks, Government of India has allowed the medical abortion methods in less than 9 weeks of Government of India recommends medical methods of abortion up to 9 weeks only. Initially, it was up to 7 weeks, but it has been extended up to 9 weeks now. So, considering the first trimester methods of abortion, we will first go on to medical methods of abortion and then the surgical methods of abortion. In the medical methods of abortion, we have two drugs which are available. One is mifepristone and the another one is mesoprestol. Mifepristone is an antiprogestin and it acts on the receptors of progesterone in the endometrium and causes a necrosis of endometrium and interferes with the continuation of pregnancy. While the mesoprestol is prostaglandin E1 analog and it causes cervical softening, uterine contractions and expulsion of the products of conception. When we have lot many other prostaglandin E1 analogs available, why we have chosen mesoprestol as the drug of choice in this? Mesoprestol is basically easily available. It can be stored at the room temperature as well as it can be absorbed by the different routes, and that is why mesoprestol is is preferable. There are protocols of mifepristone and mesoprestol for the first trimester abortion method. On day 1, Mifepristone is administered per orally, that is 200 milligram of Mifepristone is given. On the same day, if the patient is Rh negative, we need to give her anti-D dose. As in India, only 150 and 300 is microgram is available. We should give 150 microgram or 300 microgram, whichever is available. On day 3, it is up to, if the pregnancy is 7 weeks or lesser than 7 weeks, then 400 micrograms of Mesoprestol is administered. Or if it is between 7 to 9 weeks, then the Mesoprestol dose is 800 micrograms. We can either, up to 7 weeks, we can give it either per oral, buccal, sublingual, or vaginal routes. Between 7 to 9 weeks, oral route is not that effective, so mainly sublingual, buccal, and vaginal routes are preferred. In addition to these medicines, on day 3, as the patient may have some of the side effects with these medicines, we can provide them analgesics, antiemetics, and can offer them contraception. Analgesic and antiemetics as per the patient's symptoms or as per the patient's complaints. The patient will return back on day 15th for her follow-up and to confirm whether the procedure is been completely done or not. Here we will compare the methods of Mesoprestol administrations. So in the oral method of Mesoprestol administration, the absorption is quicker, but the duration of action is little shorter duration of action. So it is preferable only up to 7 weeks of duration. The side effects, the patient might have fever, nausea, or diarrhea. And the second, the buccal route has the buccal route where we keep the tablets between the gums and the cheeks, and the tablets are then swallowed after 30 minutes. The buccal route also has a quicker absorption and longer duration of action is there with the buccal route. Buccal route also has the same kind of side effect profile, but the fever or chills may be little more as compared to the other routes. Sublingual is where we put the tablets below the tongue and the patient will swallow that after 30 minutes. Sublingual has the quickest or the fastest absorption. This is the fastest route of absorption, and it has a longer and a sustained effect of the drug. This method of administration of Mesoprestol has more number of cases noted with fever, with chills, diarrhea, or the other like GI symptoms as compared to the other routes. And the vaginal routes is also the quicker route, and it has a long duration of action basically. So it stays for a longer duration. That method is also a preferred method. In the vaginal route, the tablets are placed higher up in the vaginal fornix. This slide shows us the buccal and the sublingual way of putting the Mesoprestol. This was one protocol of Mifepristone and Mesoprestol, and the second recommendation is only Mesoprestol drug. In that, which is for the lesser than 12 weeks of abortion, the dose is 800 microgram, either buccal, pervaginal, or sublingual. So we have two protocols. One is Mifepristone and Mesoprestol, and the second one is only Mesoprestol protocol. Dr. Rahul has already told who can provide the medical abortion services. Like all the primary care level providers also can provide the medical abortion facilities, but they should have the facility to refer the patients in cases of emergencies to tertiary care levels. So they should have a MOU where they have the tertiary care level giving them the authority that they can admit their patients in cases of emergency. These providers who provide medical methods of abortion can also have the other services like psychosocial support services for these patients, or counseling for the STDs, abuse support services. All these support services may be also there. If the MMA service providers can keep them, then it is better. Iron tablets or other pain medications provision should also be there at the medical methods of abortion service providers. In summary, for the medical method of abortion, on day 1, after the physical and pelvic examination, once we have confirmed the eligibility, whether she is fitting within the duration of gestation for the medical methods, like within 9 weeks, then tablet Mesoprestol is given 200 milligrams orally. And if the patient is Rh negative, then anti-D is given. You inform the patient that she has to return back to the facility after 2 days, that is on the 3rd day, for the Mesoprestol administration. She has to be provided with the phone number and the facility details where she can reach to in cases of emergencies. And we need to tell her that she may have bleeding after the dose of Mifepristone, though that bleeding will not complete the procedure of abortion, so she has to complete the total course of medical method of abortion by Mifepristone and Mesoprestol protocol. On day 3, we need to give her 400 micrograms of Mesoprestol, either sublingual, buccal, or vaginal or oral, if she is lesser than 7 weeks of gestation. We need to observe her for 4 hours and see whether she has any side effects or the drug side effects like fever, gastrointestinal side effects. Depending on the side effects, we can provide her supportive treatment like ibuprofen or hydration methods. If within 4 hours, if she starts bleeding, just check out whether she has completely aborted or the POCs are left in the vagina or at the internal os. Before leaving from the facility, do a vaginal checkup, and if the products are there at the internal os, we can do a digital evacuation and remove that. If she is in the process of abortion, we can keep her for 1 more hour and observe if she completes the abortion and she is stable or not. Once she is leaving from the facility, we have to counsel her that the mean period of bleeding with this method can be from 8 to 13 days. She may have some of the side effects like nausea, vomiting, fever, dizziness, headache, diarrhea, etc. She has to report back in the cases of excessive bleeding or severe pain in abdomen or persistent fever or dizziness. And if there is no bleeding within 24 hours after Mesoprestol administration, then also she has to report back to the facility. 75% of patients will normally abort within 4 to 13 hours after the administration of Mesoprestol. And she has to report back for the follow-up checkup on day 15. With Mesoprestol and Mifepristone method, normally, if it is an uncomplicated or a routine progress of the patient, then a routine follow-up may not be necessary with this method up to 7 weeks. If the pregnancy was between 7 to 9 weeks, then it is preferable that she reports back to the facility on day 15, just to confirm that the abortion is complete. And at the same setting, it is better that we reiterate the role of contraception to her again and counsel her for contraception. If the method of only Mesoprestol was used, then a routine follow-up is recommended. On the follow-up care, what has to be looked for? We need to see the complete recovery of the woman, ask for any symptoms of ongoing pregnancies, see whether the abortion is complete or not. See, if she was referred to some higher centers, then we need to review the medical records and the referral documents. We ask her for any symptoms which she has experienced since the procedure. Physical examination, reconfirm the completion of the procedure, and we need to counsel her for contraceptive services and provide her as early as possible. This we have already covered, the 3rd day visit on day 15th. The contraception advice, if as we have given her contraceptive advice, and if she accepts the contraception, we can give her contraception as early as on day 3rd. Once on the day 3rd, if we feel that the procedure is complete, we can give her oral hormonal methods of contraception at the same sitting, or on the day 15th as well. IUCD can be inserted on the day 15th if the procedure seems to be complete, or on the first menses after the abortion. And sterilization after 1 month of the next menstrual cycle can be taken up by the patient. We need to counsel her that she will return to her fertility as early as 14th day, as early as within 14 days from the completion of abortion. So she has to use the method of contraception as early as possible. And if there is no periods within 6 weeks of completion of abortion process, also she has to report back to rule out continuation of pregnancy. Side effects and complication. This we have already noted to some extent. Pain is one of the side effects of these medicines. The pain can be tackled by verbal support, adequate counseling, giving her mild painkillers like ibuprofen. In case of persistent pain, it is very important to rule out ectopic pregnancies, incomplete abortions, or infections. In nausea and vomiting, normally is self-limiting, so reassurance to the patient, and if it is severe, we need to hydrate the patient and give her antiemetics. Similar with the diarrhea, it is also self-limiting, so reassurance should help her. And in cases of severe cases, anti-diarrhea drugs and hydration is required. In cases of infection, we need to give her mild antibiotics to cover up the infection. On day 15th, if we feel that the procedure is not complete, we need to do the further treatment of these patients. If the medical method of abortion has failed, first thing is to find out whether what is the condition of the patient, whether it is an ongoing pregnancy, or whether it is missed abortion, or whether it is incomplete abortion. So in cases of incomplete results of medical methods of abortion, if the patient is bleeding heavily, we need to first stabilize. If the patient is stable, then we can give her another dose of Mesoprestol and observe her for next 7 days and reassess her. If the bleeding is not heavy, we can the bleeding normally if the bleeding is not heavy, we can observe her, and it resolves on its own. The abortion will be complete by the next menses. If the method is incomplete, and if there is missed abortion, or if there's a continuation of pregnancy, we should offer her surgical method and complete it by vacuum aspiration method. In cases of excessive bleeding PV, what we can call as excessive bleeding PV with this method is if the patient is soaking 2 or more pads within 2 consecutive hours, is heavy bleeding after the medical method of abortion. In these cases, we need to observe the patient, see over a period of time if the bleeding decreases, then a routine care should be provided like other medical abortion cases. If the bleeding is not decreasing, we need to keep watch on her vital signs, see if the products are in the cervical canal or in the vagina, digital evacuation of the products are done. If with that the bleeding reduces, woman and she is stable, then we need to observe the patient, monitor the vitals, and then we can observe her for 1 more or 2 hours, and we can let her go to her home. If the bleeding continues, then the sonography is required. In that, if we find the minimal decidual bits are there, then we can wait and watch in such patients. If the POCs and decidual bits with vascularity is there, we can try and repeat the dose of Mesoprestol, 600 micrograms orally or 400 micrograms sublingually. In cases of patient is not being very stable, we can go for vacuum aspiration, and continuation of pregnancy, vacuum aspiration of the continued pregnancy needs to be done. Recording and reporting of medical methods of abortion. When we are offering the medical method of abortion, like under the preview of MTP Act, then the consent form needs to be filled up. The form 1, where the RMP opinion and we take the reason behind the abortion is to be filled up. Form 2 is where the monthly reporting form goes, and Form 3 is admission register case records needs to be completed. The surgical methods of abortion methods of first trimester abortion by surgical methods. These are the vacuum aspiration methods. The vacuum aspiration methods are recommended for pregnancies lesser than 12 weeks, and the manual vacuum aspiration is what the WHO recommended as the safest method. The procedure should not be completed by sharp curettage. We have vacuum aspiration by manual vacuum aspiration and by electric methods. The manual vacuum aspiration is where the manual vacuum aspiration syringe is used. There is a handheld aspirator and we can generate a vacuum in this syringe. The aspirator is attached with the different sizes of cannulas starting from 4 to 12 millimeters. The cannulas can be operated without electricity, and they easily fit into the this handheld aspirator. The electric vacuum aspiration is another method for the vacuum aspiration method, where the electric pump is used to generate the vacuum, and the manual vacuum aspiration method, these cannulas can also be used for the electric vacuum aspiration. Before these vacuum aspiration methods, cervical priming is preferable because it makes the process to be easier to dilate the cervix, and it makes the cervix soft and it is easy to dilate. So the recommended cervical priming agents are oral mifepristone given 24 to 48 hours in advance, which is 200 milligram. 400 microgram of Mesoprestol given sublingually almost 2 to 3 hours prior to the procedure. If we give it vaginally, it should be given 3 hours prior to the procedure. The same dose, 400 micrograms Mesoprestol. And the mechanical dilatation by laminaria tent can also be used 6 to 24 hours prior to procedure. Being a surgical procedure with cervical dilatation, pain is one factor which is associated with vacuum aspiration. So very important to manage the pain. There are non-pharmacological methods and the pharmacological methods for pain management. Non-pharmacological pain management is basically giving psychological support to patient, talking to patient, making her more comfortable in the whole scene, and encouraging her to relax and breathe deeply. There are pharmacological pain management methods also, like giving her anxiolytics or giving her general anesthesia. Paracervical blocks can also be given, and providing her analgesic post-procedures. The steps for manual vacuum aspiration. We can see in these slides that by closing the wall button, we create the suction in the, we create the vacuum in the syringe. And after preparation of the area, then the syringe is inserted inside into the uterine cavity. After the dilators, which are after inserting after attaching the cannulas to the syringe, then the dilatation of the cervix is done and the cannulas inserted inside. The uterine contents are aspirated by using this vacuum which is created by the manual vacuum aspiration syringe. When do you feel that the uterus is empty? The red or the pink foam you can see is passing through the cannula. You start feeling the grating sensation over the uterus, cervix starts gripping the cannula, uterus starts contracting over the cannula, and if the patient is being given only general and only paracervical block, she may tell you that she is feeling the uterine cramping. After the procedure, we need to check the contents and confirm whether the products are complete or not. And along with that, we might go for IUCD insertion or the procedures like sterilization if the patient is opting for those procedures. Instruments need to be cleaned after the procedure by using a hypochlorite solution, that is 0.5% solution. Post-procedure care, like any Other procedure, we need to monitor her vitals carefully. We need to rule out any other complications and provide her management as needed. She may leave the facility if she's stable and meets the criteria for discharge. Ensure the woman has all the necessary information. Medications have been provided her before leaving the facility. We need to document all the outcomes of the treatment, and the adverse events needs to be documented in the registry. Aftercare is management of the complications like incomplete abortion, infection, bleeding, ongoing pregnancies. Contraception advice should be again given to her, and if she's willing, the contraceptive method has to be provided to her, and any other reproductive health needs should be fulfilled. A routine follow-up is not required unless and until the patient has some of the other complications which needs to be looked after again. In India, like these are the methods which are available for the first trimester and abortions, and India has made a historic progress in improving the success of to safe abortions. If we see the technologically, the updates are almost same in the last decades. Nothing much has been changed. As a providers, it is up to us to ensure safety and quality, especially in the context of the amended law. Along with safety, respectful abortion services is the need of the focus now, and every client and an opportunity to inform, educate, and equip with proper information on contraception and counseling. Thank you.
Thank you so much, ma'am. Thank you for such a detailed talk covering all the modalities of abortion and the methods of abortion, medical as well as surgical, and the follow-up part also, which is very important. We have one question, ma'am, in the chat section. Is admission necessary while giving Mesoprestol?
As per the guidelines, admission is not necessary, but we need to observe patient after giving her Mesoprestol for minimum 4 hours. And if she is in the process of abortion, we need to observe her for a little more till the procedure we feel it's complete and her bleeding is under control.
Okay, ma'am. Thank you, ma'am. Thank you so much for such a detailed
Can
talk.
I just ask a question here? Is it okay?
Yes, sir.
Archana,
Yes.
now Government of India is allowing by law or by the MTP Act doing medical termination in the clinics. Okay, so many of the clinics may not have the facility for keeping the patient under observation. So those doctors who are giving tablets in their clinics, are they supposed to instruct all their patients to go to the hospital at the time of taking Mesoprestol tablet for observation, or they can keep, if some clinic don't have any facility to keep patient for observation, how the things are to be managed in that situation?
These are basically the guidelines which are given by government of India. Normally, in our scenario, we give tablets to the patient and we counsel them.
Right.
If the patient feels that such and such side effects they are noting or the excessive bleeding is there, then they report back and we can refer such patient to the tertiary.
Yes. Yeah. That is what we routinely, almost every one of us is doing in that.
But the recommended medical abortion guidelines suggest that the patient should be kept under observation for 4 hours.
Yeah, right. That is actually the contradicting to the recommendation of giving it in the clinics.
Yes.
Most of the time, as long as there is no complication, no one complains with everything. But the thing is, when the law is there, when the act is there, when the rules are there, we are supposed to be law-abiding citizens.
Yeah.
We take shortcut and then get caught. There's absolutely no defense telling that.
No, it's not about the shortcut, madam. Because on one side, government is saying you can get from the clinic.
Yes,
and
I know.
Many clinics may not be having facility for observation.
Yeah, that is the thing, because
it's absolutely no problem for those who are prescribing tablets from the hospital setting. Absolutely no.
Yeah.
But for the clinics.
Yeah. But most of the clinics will be attached to a hospital.
Yeah, exactly.
Your OPD, you have your deliveries happening somewhere.
Yeah,
so
right.
Have something like that, at least on paper, that go to so and so place if there is a problem like that. It should be documented. That
right.
we should be doing.
It
takes a little more effort.
That's right.
Going forward with the next talk for today's CME. Now, to deliver the next lecture for respectable abortion care, WHO Saver Toolkit, Safe Abortion Values, Evidence and Rights Towards Respectful Bias-Free Services, I would like to invite Dr. Padmaja Veeramachandini to deliver the following lecture. Dr. Padmaja ma'am is affiliated with FOXY, IMA, FCGP, IMS, and many other prestigious organizations. She has worked as an assistant professor at PSG Medical College. She's a consultant at Alva Medical Center, Mubidri, Karnataka. She's worked in WGL 1996-1997 and in Vijayawada from 1998. She's also ran a rural health clinic at Govindarupet.
No problem.
Over to you, ma'am.
Yeah. Dr. The previous talks have already covered up extensively who can do, how it can be done, what is to be done, what are the protocols to be followed, if things go wrong, what all need to be done, everything. What I'm talking about is this Saver Kit, in which we are looking at not only safe abortion, but we're looking at the values, rights, and respects, because it is a part of the WHO and the FOXY initiative to show women that we care. And the aim of this module is to look at what are the WHO standards that say we need to meet to say we're giving respectful abortion care. And we need to look at how norms and stigma affect the services and what are the resources for this respectful abortion care. And the momentum has already been created, laws have been changed. FOXY has always taken a very active part for women to make sure that they, with the changing circumstances in life, with the act, which was very good in 1971, is not enough now. And so that is why we have these change in the law. And what we need is dissemination. And FOXY is the largest provider, so we are quite capable of doing that. Because of COVID, online training has come up possible. And medical methods uptake has increased. This makes abortion safe in the early periods. And we know that if it's an unwanted pregnancy and the pregnancy goes to 20 weeks, there is always back of the mind, there is a conflict with the PCP and DT Act. So if early we intervene, then there will be absolutely no conflict with the PCP and DT, because there's no question of sex determination at 8 weeks. And all of us have to play a role in assuring patient safety, and we need to say that respect and quality matters more than ever in this era. So respectful abortion means the care maintains not only the safety, as we all doctors do, because safety is on the top of our mind always, but also with dignity, confidentiality, freedom from harm, mistreatment, giving her the adequate information so that she can make a conscious, informed decision. And most importantly, support her during the process and after the process, so that we can offer continuously abortion. Not only abortion, we can also give contraceptive services. So as a provider, we need to treat women with dignity, empathy, regardless of our race, ethnicity, socioeconomic status. And we have to not really have a paternalistic view, Because sometimes I feel when women come for the third or fourth abortion, every time they're coming after 6 months without following any adequate contraception. So somewhere at the back of our mind, we feel, what is she doing? So irrespective of the reproductive history, we should be able to treat her without bias. As a health professional, it is our duty to listen and support and communicate with women, because we don't know the circumstances in which she's having to go through abortion. So looking at norms and stigma.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors, like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others. personally and professionally.
So you've just heard that the worst form of disrespect and abuse is physical abuse, intimidating physically, verbal abuse. And sometimes we do hear of instances of sexual abuse, and stigma we just talked about. I feel most of these don't happen, but somewhere maybe we are not so sensitive in establishing a rapport between the women. And we do have healthcare systems and the constraints that don't allow us to do, as you were just talking, that medical abortion, it's such a simple procedure. There should not be so many rules and regulations, and the system is constraining us from giving access to women. So we need to, I'm sure we all understand that every woman has a right to have freedom from harm, ill treatment, right to information, protection under the MTP and the POCSO Act, informed consent, and she can refuse services at any time, but we need to respect her choices, preferences, and give her the dignity and quality of care. We need to have timely health care to achieve highest level of health. So in the domains of respectful abortion care, we're just reiterating what was said previously. Women have a right to be free from harm, maintain their privacy, their dignity, their choices. So we need to improve our soft skills so that we can get people to give us the informed consent. And we need to provide continued access to support, better physical environment and resources, and their quality needs to be impeccable, and equitable abortion care provided by competent and motivated providers like us through FOGSI, along with contraception advice and continuity of care and counseling. So we need to strengthen the implementation of this act. As you all have heard previously, when only one provider, one registered medical practitioner is providing, it forms their responsibility to also do the counseling, contraception, referral, and compassionate care. 20 to 24 weeks is for special, in these special cases, we need to have more sensitivity, give a judgment-free service and timely services where, and confidentiality and safety are the priorities always. So we need to avoid stigmatizing language. This is another brief video that shows that.
Messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix side denotes killing, which is not appropriate when describing abortion. When referring to sex selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, It is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
So after that entire word game, there are on the net self-paced game. It makes you look at our own biases, so you can try it out at these sites. And just to recap some of the things, from 1970, we had the MTP Act to try to decrease the unsafe abortions. In spite of that, there were a lot of unsafe abortions. In 2000s, people awareness increased and safe abortions increased. Now from 2020, we are changing it to a respectful abortion. So just to make sure that the 34 participants are still awake and not asleep, we just have some statements in the chat box. If you can put up true or false, we will run through this. According to the WHO, restricting access reduces the number of abortions. Do you think it is true? You're looking at the chat box. There's no one answering. Yes, it is false. We have Dr. Rahul Mani who's here. It's false. So basically, access, appropriate methods, and trained people are necessary to make it safe. Great. MTP Amendment 2021 requires a minor to obtain written consent from parents and guardians before she can undergo termination. Is it true or false? People wake up. No. Basically, she does not need consent from her parents or guardian. Anyone who is accompanying her and is an adult and takes responsibility, we can take their consent. A 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Would you ask her to continue just because it has reached the age of viability? I totally agree with Ashwini and Dr. Neena. We will not say continue the pregnancy because her social status has changed and she is not willing to continue this pregnancy. It is her right. But because it is 22 weeks, we will need 2 registered medical practitioners to agree to do that. In India, abortion is legal. Let us make it safe and respectful. And I thank you all for the patient hearing and having me here at your society. It has been great talking to you all, and Rahul and Ankita and Santosh. Thank you.
Thank you, ma'am. Thank you for
Thank you so much, ma'am.
to be with us. Yes, Ankita, you can continue.
Thank you so much, ma'am. Thank you for that wonderful window into the safe abortion practices. And yes, in India, abortion is legal, and safe and respectful abortion is the way ahead. Now, coming to the concluding talk of today's CME, today's webinar on respectful abortion care, the last lecture will be, I request Dr. Krutika Arunachalam to deliver pre and post abortion follow-up counseling, leveraging technology for referrals and online consultations.
Okay. Thank you, Dr. Krutika. Yeah, so I'm just waiting to be made host so I can share the screen. But while we do that,
yes,
I'm following a lecture after the respectful abortion care. And my topic is pre and post abortion counseling for family planning. And I'll be also talking about leveraging technologies for referrals, which is online consultation. So until that is done, I'm just going to start my talk. And what is counseling? So counseling is basically a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. I'm just going to share my screen. Give me a minute.
I'll take this minute to give a short introduction about our speaker. Dr. Krutika Arunachalam is a consultant at Dr. Khopkar Hospital and a consultant at Ankur Fertility Clinic. And she's a trainer at Lakshya Manyata.
Okay, can you see my screen?
Yes, ma'am.
So,
yes, ma'am. The screen is visible.
Thank you, doctor. Now coming to pre and post abortion counseling. Now these are integral part of comprehensive abortion services. It is as important as our respectful abortion care. Women may need help in decision making, and this is the abortion counseling that will help. And whenever needed, a spouse can also be counseled. Now, pre-procedure counseling, it holds a critical role because it helps a woman to decide about the termination of pregnancy. It helps her to choose the correct method for termination. It ensures her to deliver, to give complete information about this procedure. And it also helps a woman to adopt a contraceptive method to doing so. Now, what is this procedure to follow for a pre-procedure counseling? First is we ensure the privacy and confidentiality of the patient. We be non-judgmental and sensitive towards the patient. We establish a rapport. We use simple language and allow the woman to clarify her doubts. And if she has made up her mind for termination of pregnancy, we assess her for the procedure. Now, relevance of pre-abortion family planning counseling. Why is it relevant? Because there is a quick return of fertility. This is the opportune time for contraception acceptance. A minimum 6 months gap is always good before the next pregnancy, and it gives us health benefits and better future pregnancy outcomes. Always, there is a 90% abortion-related maternal mortality that can be prevented by ensuring contraception, and hence contraception counseling is important. Pre-abortion family planning counseling. When do we start this? Well, it can be started in the first visit. That's the first consultation. Exception, of course, being grief management, like in case of missed abortion. And what to counsel? Well, it is important to let them know that the return of fertility can occur anywhere between 10 days to 4 weeks. We help them with the choices, method-specific counseling, and high-risk behavior whenever it is applicable. Now, if a woman is not willing for contraceptive method, do not refuse MTP. Try to counsel her after the procedure, and if she's still not willing, call her for follow-up in a week's time and counsel. Now, assessing suitability for post-abortion contraception. Now, these are just the general guiding rules. One being abortion should be complete. Second is there should be no existing infection. There should be no injuries to the genital organ, and chances of fresh pregnancy should be ruled out. A post-procedure counseling. Now, until now, we spoke about pre-procedure counseling and peri-procedure counseling. Now, coming to post-procedure counseling, it also has a critical role. Why? Because it ensures women to have understood the precautions and the care that is needed in the post-abortion period. The opportunity to counsel for contraception in case of not previously accepted, and reinforces the need for continuing the use of contraceptive method chosen. Now, how does this procedure go about? Well, we start with continue. We continue to ensure the privacy and confidentiality. There is reassurance. We reassure her in case of any problems, and we repeat the information about post-procedure care and danger signs. Now, post-abortion family planning counseling, when it has already been adopted, we appreciate the effort. We give immediate care in the form of IUDs or MPAs. Or if it's ongoing, we give OC pills, follow-up protocol, continuity, and cards. If they're undecided, then we allay their anxiety. Importance of immediate adoption and chosen, we help them to do that. Extended period of adoption, couple counseling, and EC pills. Now, post-abortion contraceptive methods. Post-abortion contraceptive methods, we're going to divide it into first trimester and second trimester. First, when we discuss is the barrier method, that is the condoms. First trimester, it can be used as soon as possible, as soon as the activity is resumed, and so goes with the second trimester. Because it is non-hormonal, there are no side effects. It can be used without consulting a healthcare provider. It is easily available. There is prevention of STIs, including HIV. It enables men to take responsibility for contraception. Second method is the intrauterine contraceptive device. Intrauterine contraceptive device like IUD 380A and IUCD 375. In the first trimester, it can be inserted immediately or up to 12 days after confirmation of completed abortion. So, and with medical abortions, inserted around 15 days of the procedure, provided there is complete expulsion is confirmed and the risk or presence of infection or any other contraindications is ruled out. Second trimester, it can be inserted immediately or up to 12 days after the procedure is complete and contraindications are ruled out. This is a highly effective method. It provides long-term contraception for up to 5 years in case of 375 and 10 years in case of 380A. It can be provided by a trained doctor, MBBS and above, ANM and nurses after first trimester surgical abortions, by trained doctors only after medical abortion, and by PPIUD trained doctors after second trimester abortion. There is no interference with sex, immediate return to fertility on removal, and no hormonal side effects. Coming to hormonal contraception, combined oral contraceptives. In the first trimester, it can be used immediately or up to 7 days after abortion using surgical methods. In case of medical abortions, it can be started on day 3 with the dose of Mesoprestol or within day 15 of the procedure after confirmation of complete abortion. Second trimester, it can be used immediately or up to 7 days after abortion. This can be used because it regulates the menstrual cycles. It can be provided by all health workers after the first screening by trained providers. There is no interference with sex. Offers protections against ectopic pregnancy, endometrial and ovarian cancers, and benign diseases like fibrocystic and fibroadenomatosis. Not suitable for women who are breastfeeding babies less than 6 months old. Other form of hormonal contraceptions are the long-term injectables like medroxyprogesterone acetate. In the first trimester, they can be used immediately or up to 7 days after abortion using surgical method. With medical methods, it can be started from day 3 with Mesoprestol. In the second trimester, it can be used immediately or up to 7 days after abortion. They are highly effective, and the confidentiality and privacy is maintained. It can be provided by doctors, MBBS and above, Ayush, ANMs, nurses after screening by the doctor, which is MBBS and above for the first injection. There is no interference with sex, no effect on quality or quantity of breast milk, no estrogenic side effects, offers protections against ectopic pregnancies, ovarian cancers, iron deficiency anemia, and uterine fibroids. Now coming to permanent methods like female sterilization, in the first trimester, they can be performed after an abortion in the absence of any infection or severe blood loss, concurrently or up to 7 days. Both mini lab and laparoscopic sterilization can be done. With medical management, with medical abortions, it can be done only after the first menstrual cycle. In second trimester, mini lab sterilization can be performed concurrently or up to 7 days after the abortion in the absence of infection or severe blood loss. Laparoscopic sterilization is not recommended here. Here, this is a permanent method of contraception, highly effective. It is effective immediately. There is no interference with sex, no effect on breastfeeding, no long-term side effects, and offers protections against ovarian cancer. Now, vasectomy, this can be performed anytime independent of the timing and procedure of abortions as it is performed on the males. It is highly effective, permanent method of contraception, no interference with sex, and no long-term health risk. And the couple must use barrier contraception for up to 3 months after the procedure. This is just a tabular form just to go through the contraceptive methods that can be used. With a medical abortion, OC pills start from day 3 or day 15 after the process is assured as complete. Injectable contraception start from day 3. Centchromine, also known as Saheli here in India, start from day 3. IUD is from day 15. And TL, like we mentioned earlier. So with vacuum aspiration, OC pills can be given after the procedures. And so is the case with injective DMPS and centchromine. IUD can also be inserted and TLs can be done. Now coming to sexual reproductive health services using teleconsultation and other technology. Leveraging technology, that is service provisions, we can use teleconsultations, telecounseling, teleguidance, telereference, and telelinkage. Leveraging these technologies, that is techno information, education, and consultation, can be done using these website. The website is Hamdo. Social media like Ask Tanu and YouTube, infographics, helpline, patient education platforms like WHO, Ministry of Health, of Family Planning and Welfare, and RCOG. Now, coming to what is the SWOT of telecommunications, it stands for strength, weakness, opportunity, and threat. The strength, it's because it's the COVID era, everybody is quite well versed with online communications. It is approachable throughout the process, and there's awareness that is spread out, questions can be answered at ease. The weakness being this is not face-to-face and demonstrations cannot be possible. It is an opportunity to give that kind of privacy and comfort. It is cost saving, it cuts down the visits. And threats, because it is an online process, one can miss opportunities and also misdiagnose. Applicability for components of CACs, that is assessment, confirm the diagnosis and contraceptive need, counseling, video conference and Zoom, and we can follow up by hybrid services, maybe 1 visit, MMA 3 visits. Key message here of this talk is that we realize the need for post-abortion family planning, bring the couple on board and strive for 100% coverage, capitalize on basket and applicability of post-abortion period, technology as far as possible, scope for entry of CAC services, concern, policy, malpractice, service costs and assess, And adolescent reproductive health needs both online and offline services. Thank you very much. There is a post-test that you need to fill after this.
Thank you so much, ma'am. Thank you for such a wonderful and such a crisp lecture and with bullet points on what are the family planning facilities that we can give to the patient and how counseling is a very important part for both the male partner as well as the female partner.
Thank you, Dr. Ankita.
This brings us to the end of the session today. I would like to thank our esteemed speakers for the evening. And I would like to thank Foxy for giving us this opportunity and NMOGS for providing the platform about this discussion about respectable abortion care, the most needed discussion of the hour after the new amendments have come. I would like to thank Dr. Rahul Vani, our president, Dr. Santosh Jaibhai, our honorary secretary, and Dr. Bandita Sinha, our treasurer, NMOGS. To the delegates, now I'm going to share a link in the chat section. Kindly click on the link and give the feedback. Also, if somebody is not able to click on the link and give the feedback, when you're about to leave the meeting, another window pop-up will come on the screen on which you can press and you can give the feedback for the same. A very thank you to all our delegates for the evening. Thank you, everybody. Any questions? We have some time to take the questions. If any questions, they can be presented in the chat box or we can ask them live.
I think special thanks to Dr. Padmaja again being with us and being with us throughout the session. And Dr. Ankita also, for she's always ever ready to do an MOC for any of our webinars.
Thank you so much, sir. Sir, I just have one question, if I may.
Yes, please.
In this entire abortion care that we have been talking about 18 plus years, and we have been talking about what consents to be taken. And as we have learned that any adult accompanying them and who's ready to take responsibility can give the consent. But how about us approaching this young teenage kids who approach us prior to indulging or starting their sex life? We counsel them about HPV vaccination. We counsel them about contraceptions. So is it the right time also to counsel them about the abortion care or the abortion facilities or the types of abortions that are available? Because we see a lot of these kids taking emergency contraceptives, purchasing them off the counter. So we do come across such cases in our every day-to-day practice. Is that also, I think, is a part of respectable abortion care, providing or giving awareness?
Yes, it is a part. So we are not supposed to be judgmental. Now, if a person has approached to you with a request for a service, you need to see how best you can give the service. Counseling is a part of it, and these kids or adolescent girls will need detailed counseling. And you have to tell them that abstinence is one of the best ways of preventing pregnancies or preventing yourselves from sexually transmitted infections. But then you just have to counsel, give them the information, and the ultimate choice is theirs. You have to leave it up to them. You can give your best counseling, and ultimately the decision is theirs.
One thing is we have to remember we are all under the POXO Act.
Yeah.
So
yes,
if we are providing service to someone who's less than 18 years, it is important that we notify the police. So it clashes with the confidentiality. So that is one thing. But what we were told, we had this discussion even with Dr. Jaideep Tank, who was also part of this MTP amendments committees and all that. So he said the easiest thing is put in, write on paper that Miss of so and so from this sort of don't give the name, file number so and so had contacted us. She is underage, and as a part of as a responsible citizens for this POXO Act, we are intimating to you, and send that letter to the nearest post office with the acknowledgement card, so that the acknowledgement comes back to you. Otherwise, we'll have to send a person, they'll have to sign, all that is a big headache. So just post a letter and keep the acknowledgement card with you to say that, because if there is a legal hassle later on, someone puts a rape case, we are called to the police station, and then we will be made a part of the whole process that we knew it and we did not inform.
Yeah.
That will be our responsibility.
As far as the POXO Act is concerned, you need to inform if there is evidence of pregnancy or if she's pregnant.
Yeah, she's pregnant.
The rest of the thing of counseling and everything is a part of education. Is a part of education. So that counseling and this sex education is done in schools also. So as a part, if a patient has approached us for some information, as a part of counseling, you can definitely give this counseling. But if she is pregnant, then you definitely have to inform the police. So there is no two ways out of it. Then it becomes a criminal offense. So you have to inform.
Yeah.
Now, as far as rape cases go and rape survivors go, you don't need evidence. You don't need an evidence that she's actually raped. An allegation is sufficient enough. The only thing you have to be careful is that police FIR has been filed, and you have to provide an information. You are not the complainant. You are just providing the information to the police. It is up to the police and the patient whether they want to proceed with the case or not. Your job is to inform the police. You are not the complainant. You are just providing the information.
Right, sir. Okay. Thank you so much. I would again request our delegates to please click on the link and post the required feedback to complete the certification course. Also, if the link is not functional while leaving the meeting, a window will pop up for the same. The feedback can be submitted there also.
So with your permission, Dr. Rahul Wani, can we leave the meeting?
Yes, sure.
Thank you. Thank you.
Thank you, madam.
Thank you, sir. Thank you, everybody.
Thank you, Ajay sir, and the whole team, backup team, which is working behind the scene.
Yes.
Thank you, sir.
Thank you.
Thank you, everyone. Have a good evening.
Thank you, ma'am. She's the same.